Okay. Well, in presentation mode. All right. So today we are going to learn all about interpreting formal evaluations. Now, my name is Sydney, and I am a speech language pathologist at A2 Therapy Works. So a lot of what I talk about today is going to be more about speech and language evaluations, but a lot of it crosses over into other types of therapy evaluations. So you'll find that a lot of what we talk about will be applicable for lots of different therapies. So here are the things we'll cover. We're going to talk a little bit about what to expect before the evaluation and on evaluation day, parts of an evaluation report, test scores, and goals. So this is just another overview. It breaks down a little bit more about the details we're going to go into, especially with test scores. That is an area that we'll definitely spend some more time on because it can be a little bit tricky to understand all of the different scores that you'll see on a report. All right, so before the evaluation, so you've called, or this might be through school, but you know your child is going to be receiving an evaluation. It's really important that you complete and return all of the intake paperwork prior to the evaluation. We can accept it the day of an evaluation, but the more details you provide and the more details we have in advance will help us do a better job at selecting the right evaluation for your child. It's also really important for you to provide any previous therapy evaluations or reports. Even if it's maybe you got an evaluation somewhere else or there was previous therapy and you don't agree with it, it's still important that we have it and we can kind of go through and talk about all of the areas that you really liked in the report, maybe areas that you're hoping will be a little bit different going forward. But we like to have all of that paperwork because it just helps us have a better idea of your child's needs and how we can help them. Now, before you go to the evaluation, it might be a good idea to write down any questions or information that you would really like to learn or share on evaluation day. I say write down because when you get to the evaluation, things can start to move pretty fast. It can be, I don't like to say stressful, but it can be, a little bit higher stress, and you might forget some things that you really wanted to ask. So if you have them written down, you can make sure you take some time at the beginning, middle, or end of the evaluation to ask the therapist or let them know any of that important information. And then depending on your child's age and the concerns you have, it might be helpful for you to record some videos of them playing, talking, doing things at home, because sometimes when we get kiddos in for the evaluation, they might not do everything that they're doing at home or doing at school. So it can be helpful for us to see how they interact in a more natural and an environment that they're used to and more comfortable in. So that's something that the therapist and you might talk about before, and the therapist may request that you bring some videos or send them in advance. And then try to make sure your child is well rested and fed before the evaluation. Not always possible, and we will work with your child at whatever level they're at. I mean, if it's a tough day and they didn't want to eat or they didn't sleep well, we will still do the evaluation and still get a lot of good information. But if possible, make sure they are nice and ready for evaluation day. So evaluation day, what's being assessed? And like I said before, a lot of this is going to focus more on speech and language because that's what I do. But depending on what type of therapy your child is attending the evaluation for, the skills being assessed will be different. So we'll go into a little bit more detail on a few of these, but some of the areas that will be assessed in almost every evaluation will be completing a parent interview and play and interaction skills. So depending on your child's age, it might be a bigger or smaller portion of the evaluation, but those two areas we're typically always looking at and always completing. And then from there, depending on what your concerns were during the intake process and what you filled out on your forms, we're going to maybe look at social skills, speech skills, language, their oral structures, voice, fluency, which is stuttering, or literacy, reading. So it really just depends on the information you provided us in advance. And that's, again, why it's really important for us to have as much information as possible so we can choose the right assessments and be prepared on evaluation day. Okay, so a little bit more on the parent interview. Now, interviews sometimes can seem a little bit intimidating because you're getting asked a lot of questions and you want to make sure you're giving the right answer. But for these interviews, there's not a right or wrong answer. We're just trying to learn about your child, your family, what you're hoping to get out of therapy, how we can help your child. So we're going to ask, about your main concerns. And then from there, once you let us know, we're going to ask more questions and try to get that full picture of your child. We'll want to know how they communicate at home, in school, in the community, because we're only seeing them in this one therapy room. And it's not a familiar environment. So we probably won't see them do as much as they do at home or in the community. So we'll want to know about that. We'll want to know medical history, their school information. If this is a school evaluation, they might want to know about outside therapies or other things happening, and much more. So really the questions that you'll be asked are going to depend on what your concerns are. But it's really important to just be as honest as you can and provide as much information, since you know your child the best. You're the one that's with them every day. You know all of the ins and outs. So we just need you to tell us everything. And I know sometimes when your child's being assessed for a therapy, there's pressure to have them meeting all of these developmental milestones. And sometimes as parents, we might feel the need to exaggerate things a little bit, but when you're getting evaluated for any kind of therapy, it's important just to be as honest about where they're at with their development, so then we can evaluate them appropriately, and then we can choose the right goals and ways to target those goals. So that's why we just appreciate you giving us as much information as you can. And then if you forget anything on evaluation day, don't fret. You can call or email your therapist after the evaluation. Sometimes evaluations are written immediately after the session, but typically those are written within a week after. So there's some time for you to reach out to the therapist and let them know anything else that you may have forgotten to tell them or ask. Just let them know. You'll have their contact information after. And then play and interaction. I wanted to talk a little bit more about this because I think this is pretty common in most evaluations. So play is your child's occupation. Play is how children learn. So evaluations might look like we are just playing with your child. It might not seem like we're doing a whole lot, but while we're playing with your child, we're looking at a lot of different areas and really trying to learn about where your child's at and things that we might need to work on. So depending on your child's age, this could be a really big portion of the evaluation, or it could be a small portion, but typically there will be a play portion of the evaluation. So what we're looking at tons of things. I just listed a few things here. We might be looking at your child playing alone versus playing with others, their pretend play, if they're doing a nice job with sharing, turn taking, how long they're able to play with one activity. Are they able to sit and play with one toy for 5 minutes, or are they going all over the room and playing with different things? And then how your child is interacting with you, a more familiar person, and the therapist, an unfamiliar person, and et cetera, because we are going to be looking at tons of different things. And then when you're in this session with your child, be prepared to get on the floor and play, because as a therapist, we're a new person. Your child's more unfamiliar with us and they might not be as comfortable. So as the parent, a lot of times we will try to include you in the evaluation, and we may even ask you to help us get some portions of the evaluation done, because your child's more likely to respond to you versus us at first, because they don't know us yet. So be prepared to be an active participant in the evaluation. Okay, so types of assessments. So these are some terms that you may have heard before, maybe not, but we'll go and explain these different terms that you'll hear during the evaluation and after. So formal versus informal assessments. I feel like these terms are used pretty often, and typically formal assessments, that's referring to standardized tests. So those are tests with statistical reliability and validity. So we'll go into more details on that, but that's what we're typically referring to when we say formal assessments. And then informal assessments, those are the observations that we're making. We might be using checklists. We might be using our own clinical knowledge and experience. So those measures are still just as important, but they're not following a standardized protocol like the formal assessments are. So going into standardized assessments, these are assessments that require all test takers to answer the same questions in the same way, and it's scored in a consistent way. So that's why it's standardized. These tests were tested on different groups of children, and they were normed and went through all of these steps to become standardized assessments. So there are a few different types of standardized assessments. We won't go into too much detail on these, but your child may receive both kinds of tests, maybe just one, maybe none, but it's good to be familiar with these terms. So norm reference tests. So this is where tests compare and rank individuals in relation to one another. So it compares your child or the individual to a large group of individuals. Typically gives us a percentile rank, which we'll talk more about, and it tells us if the individual is below or above average. So an example of a norm reference test would be the Goldman-Bristow test of articulation. So that's a test that we give a lot as speech therapists. And then a criterion reference test. These are tests that measure an individual's performance against a set of criteria or standards. So it's not necessarily comparing the individual to a group of individuals. It's more comparing them to a set of standards that we would expect the child to be at. So it compares your child to the expected stage of development or level of education. And it also will tell us if they're below or above average. So an example for that would be the stuttering severity instrument, which is something we may give for a fluency evaluation. Now, it's important to note standardized tests are important for insurance approval. They're important in the schools to make sure your child's eligible. I like to just make the note that standardized assessments don't tell us everything about your child, not even close, but a lot of times we do have to complete these types of assessments to make sure your child is covered for therapy. So parts of an evaluation report. So your child has been assessed, evaluation day happens, and then you get this report after. And I know a lot of times the report can be pretty long. It might have a lot of words you're not familiar with. It's written in different language that you're not used to reading. So it'll help to kind of break it down and know the different parts and what types of information will be in each part of the report. So what I wrote here, this is how the reports at A2 Therapy works. This is kind of the template that we follow. Might be different in school, it might be different in other clinics, but all of these areas, all of this information will be in the report somewhere. So you can pay attention for these different words and then look into the report to find them. So the demographics section, this is just basic information. So address, age, preferred language. We'll sometimes have medical or treatment codes that we have to use for insurance in there. And this is really just a lot of the information that we collected at intake or that you filled out when you completed the intake packet. And then history. So this is all of the information that you provided during intake and during the evaluation. So that's why it's really important for us to have a lot of information. So then when we are writing the report, we can really have the full picture of your child and we can make sure all of the important information is in the report. Evaluation results. So this is usually, I would say this is usually one of the biggest sections of the report because this is where you will see all of the tests that were administered and the scores, and you'll also see more details on the informal observations or checklist or whatever your therapist was completing. You'll get to read more about that there. So yeah, like I said, that's usually kind of a long portion of the report and usually a really important part to read. Next is usually a prognosis. So what a prognosis is, it's just an estimate of how your child will improve with therapy. And really pay attention to the word estimate because truly none of us know exactly how children will improve. So we try to estimate based on a few factors. It might be based on your child's age, based on the family support at home. But generally when we're working with children, we don't generally give a bad prognosis. I would say going into an evaluation and treatment with a child, prognosis is typically always good because they're young enough and they have that support. You're bringing them to an evaluation. So we likely always see progress in therapy. Next would be recommendations. So in this section, we will highlight what we recommend for duration. So how long therapy sessions should be. They can be anywhere from 30 minutes, 45 minutes. Some places they may be an hour. And then frequency of therapy sessions. So if we recommend once a week, twice a week, 3 times a week, that really just depends on what we found during the evaluation and what we think your child would benefit from. In this section, we also might include different clinical strategies that we will use during therapy sessions to support your child. So in our reports, we like to give examples of the strategies we're using. So then, you know, when you're reading the report, these are the types of cues and supports my child will receive during therapy sessions. And then last is typically proposed goals. So it's really important to pay attention to the word proposed here, because while we're the ones that write the evaluation report, you are also a part of approving that report and making sure that you are on board with everything we're working on. So if you read the report and there's 1 or 2 goals that you don't think your child needs to work on or you think need to be modified, this is why we just say they're proposed, because we want to work with you and talk with you and make sure that these goals reflect what we think your child needs and also what your goals are for therapy. So we'll propose the goals and then we can work together to change them and help them suit what both of our goals are for your child. Okay, now test scores. So this is definitely a dense portion of this presentation because we have to go into numbers and bell curves and all these different things, but I will try my best to explain these to you because I think it's really important that you have at least an idea of what scores, what numbers you're looking at. You'll see a lot of numbers and I'm hopeful that you'll just have a better idea of what they actually mean. So the most important thing I want to take away from this is that the test scores do not represent your child in any sense. So like I said earlier, we have to complete these assessments typically for insurance purposes. In the school, it's for eligibility. But as therapists, we don't use these scores to guide our goal writing. We don't stress about the scores. Really, it's just something that we have to complete. We're more interested in what your child did during the test or what was tricky during the test. We don't get stuck on the number, and it's our goal to make sure parents don't get stuck on that number either, because sometimes it can be kind of tough to see certain scores. So I just want to make sure you know that while test scores might be important, they do not give us the full picture of your child by any means. They don't take into account what your child's like at home, what they do in this situation. It's only what they did this one day in this one new room with a new person. So just keep that in mind when you're looking at test scores. So in the next few slides, we're going to look at a bell curve that we'll keep going back to because that's something that will be used in all assessments. And then we'll go through the different types of scores that you may see on your child's report. So here is the bell curve. I won't talk a ton about this now because we're going to keep going back to it as we go forward. But some important parts of this bell curve, we have in the middle here. I'm sorry, I'm just going to grab so I can write on here. So in the middle, we have the mean. Oh, that was a weird line. Okay. So the mean is always 100, and that can get a little bit confusing because a lot of times we look at 100 as perfect, like a perfect score is 100%. While when it comes to test scores, 100 is actually right in the middle. So that's the average of whatever test is being given. So we'll go into more details in the next few slides, but just so you always know, keep that in mind. The average is always 100, and then it goes up and down from there. And then another term we will use a lot is standard deviation. So you can see on here, there's this SD written after the numbers. So the standard deviation is the average distance from the mean. So the average distance from 100, or there's other numbers we'll go into, but that average distance from the mean. And for most tests, the one standard deviation is 15 below or 15 above the mean. So like you can see down here, the mean is 100 and one standard deviation below is 85 and one standard deviation above is 115. So that 15 number will be important too as we learn a little bit more about scores. Okay, let's go. There we go. Okay. Oh, those marks are still there. You can see I do not use Zoom often. Clear drawings. Okay. So the first score that will be reported is typically the raw score. So the raw score is just the number of items the individual answered correctly on the test. So when comparing the score to other individuals and trying to really judge where your child's at, the raw score doesn't really mean anything. For us, it's just how many they got right, and then we use that score to then change it into standard scores and numbers that actually show us where they're at on that bell curve. So like I said, here, these numbers are converted into standard or scaled scores. The raw score doesn't mean a whole lot, but it could be helpful if your child's given the same test yearly, as you can compare raw scores to measure progress. So like, for example, if your child was given a language assessment and they had a raw score of 15 one year, and then the next year they had a raw score of 30, well, that would tell you that they improved because they got 15 more test items correct. So it won't tell you a whole lot about the average, but it could be helpful if your child's given the same assessment year to year. So I have an example down here that we're going to use as we go through test scores. So we have Sam, who's 5 years old. He received a raw score of 15 on a language assessment. And Bob, who is 5 years old, he received a raw score of 50 on the same language assessment. So we'll keep going back to those two. Okay, there we go. All right, so next is the standard score. So this is pretty common to most tests. This is a score you're going to see a lot. And the standard score is a score based on a scale with an average score of 100. So if we think back to that bell curve, I'll go back to that in a second. The average score is always 100. So an average standard score is 100. So if your child received a score of 100, that would tell you they are right in the middle. They are average in regards to that test. So it's a way of showing us how close an individual score is to the average score of the sample. So if we go back to what a standardized test is, they collected a sample, they found the average for different ages, and then once we score a child, it'll tell us how close they are to the average of the sample. So it takes into account age. Some tests will take into account gender. There's one articulation test that I can think of that does. I'm not sure if there are a lot of others that do, but there are different things taken into account. So when we're looking up that standard score, we're not going to compare a 5-year-old to a 20-year-old. We're only comparing the 5-year-old to other 5-year-olds. So for standard scores, one standard deviation below or above the mean is 15. And since the average score is always 100, scores one standard deviation above and one below are considered average. So scores between 85 and 115 are considered in that normal range. I know it sounds like a lot, it's a little bit confusing to follow, but if we go back to the bell curve, you can see here we have the mean in the middle, the 100, and then if we go one standard deviation below 85, they're still in that normal range. One standard deviation above 115, they're still considered in that average range. So if we go back to our friends Sam and Bob, so we took Sam's raw score of 15 and we converted it into the standard score of 62. So whenever we give a test, we have test booklets that help us do this. So his standard score is 62, and then Bob's raw score of 50 was converted to a standard score of 115. So if we look back, a score of 62, that is going to fall, oh, sorry, having my Zoom troubles here. The score of 63, that will fall kind of in the middle here. So between 3 standard deviations below and 2 standard deviations below. But then our friend Bob, his score of 115, that falls right here. He's 1 standard deviation above the mean. So he would fall in that average range. All right, and then if we go back, here, so we just talked about their standard scores, and then, Um, I also wanted to note that some insurance companies and schools, they might have certain standard scores your child has to receive to be eligible for services. So like certain insurance plans, they have to be so far below the mean to receive services. And I know in schools too, it's the same thing. They have to be so far below. So depending on the plan, if they score a certain score, if they're too close to that mean, they might not be able to have services covered by insurance. However, that doesn't mean they don't need services. So just because they scored average on one assessment doesn't mean that they don't have other areas that they may need to work on. You know, we're still completing those informal assessments, and we may have found that there's a certain area they really need to work on, but we weren't able to assess that formally and give a score. So it's kind of important to know that even if they're in that 85 to 115, they still may need therapy, even though they're in the average range. So now we go into scaled scores. This is very similar to a standard score, but the numbers are a little bit different. So it really just depends on the assessment we're giving. Some assessments we will get scaled scores on, other assessments we'll get standard scores on. Really just depends on the test. But we use the numbers the same way, they're just different. So the average scaled score is 10. So we remember for standard scores, average is 100, scaled scores, average is 10. Same as the standard score, it's a way of showing us how close an individual score is to the average score in the sample. One standard deviation below and above is 3. So therefore, the average scaled scores are between 7 and 13. So if we go back to Sam and Bob, Sam's raw score was converted into a scaled score of 2, and Bob's raw score was converted into a scaled score of 13. So as we can see, Bob's score, he falls in that average range at 13, but Sam's score of 2, that falls pretty significantly below the average range. I won't go back to the bell curve on this one, but if we think back to that, we can kind of picture where it would be at on that curve. Next, we have percentile ranks. So percentile ranks will come along with the scaled and standard scores, usually reported in the same table or however it's reported. But this just tells us what percentage of the test sample scored equal to or less than an individual's score. So it'll make more sense when we put numbers to it, but it just compares the individual's standard or scaled score to other individuals in the same age or in the same grade. So it's important to know that your child is only being compared to same age or same grade peers. So if we went back to our bell curve, I'll go back in a second, but we can see Sam's percentile rank is 1. So after we got his scaled score and standard score, we turn that into a percentile rank and it's 1. So that means that Sam scored as well or better than 1% of the sample, and 99% of the sample achieved a higher score than Sam. Now Bob's percentile rank was 84. So that means that Bob scored as well or better than 84% of the sample, and 16% of the sample achieved a higher score. So you can see that Bob's percentile rank is much higher than Sam's. And if we look back at our bell curve way back here, you can see at the very bottom here is where we find percentile ranks. So we had Sam was closer to 3 standard deviations below the mean. He was kind of in the middle. So you can see at the very bottom percentile rank, he's in that 1 range. But then if we went over to the score of 115, where Bob was at, he's in that 80 to 90 percentile range. And then it just keeps going up from there. All right, so the last score that may be reported is an age equivalency. I think that this score is pretty easy to comprehend versus the other scores we just learned about. This one makes sense to parents, and it makes sense to pretty much everyone a little bit easier than the other scores. However, it's a really misleading score. So I do not find that this score is helpful in telling us where your child's actually at. So it doesn't really give us a good idea of their actual skill level. The age equivalency, it basically represents the average score, the mean of the sample for a particular age group. So the example I have here, the age equivalent score of 5-year 1 month. So if your child took a test and their age equivalent was 5-year 1 month, that just corresponds to the average raw score obtained by a 5-year 1 month old child in the sample population. So it's the average of all 5-year-olds that were in the sample. It just tells us if your child scored in that average. Did they score like other 5-year, 1-month olds? But basically, these scores don't take into account the range of normal performance. Because if you remember, for standard scores, the range was 85 to 115. Now, in age equivalency, we don't get a range like that. They just tell us this is the age the child is at, but it doesn't take into account any other factors. So I wrote down an example here that I thought was helpful for really envisioning why this score can be kind of problematic. So if I gave an articulation assessment to a 12-year-old who struggles with the R sound, the ers, and they might score an age equivalency of 4 years, 2 months old. Now, do we think the 12-year-old is functioning like a 4-year-old? No, but they got that score because they struggled with the R sound. So their raw score, they missed so many test items because they struggle with that one sound. That puts them at the 4-year-old age equivalency, but that doesn't really make sense because when you talk to this 12-year-old, they don't sound like a 4-year-old, they don't act like a 4-year-old. So it can be pretty problematic to report that. And it can be a little bit scary as a parent if you have a 5-year-old child and the age equivalency is 1-year-old, you know your child better than that. You know, odds are they are not functioning like a 1-year-old. So we don't report age equivalency on our reports, but there may be some people who still do report that. So I would just recommend if you see that score reported, I would recommend to just ignore it. Try not to think too much about it. If you are really concerned about it, I would recommend talking to your child's therapist to try to learn more and really understand, you know, your child's strengths and the areas to work on versus focusing on just that age equivalency. Okay, so our the last part of this, we are going to talk a little bit about goals. So goals are going to look different. It really just depends on what your child needs to work on. But goals should follow a similar format. They should have certain parts. They might look different depending on the therapist, but we want to make sure they have all of these parts. So I'm sure some of you have heard of SMART goals. These are used for personal goal setting. They're used in the workplace. We also try to follow a similar format when we're writing goals for our clients. So here's all of the areas that you're going to want to look for when reading your child's goals. So first of all, we want to make sure they are specific. So what do we want the child to be able to do? That's really what we're looking for. It needs to be very clear what our expectation for the child is. Measurable. So how are we going to know when the child reached their goal? How are we going to be tracking data to measure their progress? We need to make sure there's some sort of number or some way for us to actually track the goal. Achievable. So is this skill something in your child's current level of functioning? So where your child's at right now, is this an achievable goal? Or are we asking a 1-year-old to do something that's in the 4-year-old range? That wouldn't really be achievable. So we have to really, you know, assess where your child's at and make sure it's an achievable goal. Realistic. So is this something your child can reasonably accomplish in a time frame? So if I had a 2-year-old and I wanted them to make the R sound, wouldn't really be realistic because we don't typically see that sound until 5 years old. That's when we expect children to have it. So we want to make sure that the goals that we're writing are realistic for where your child's at. And then timely. So what's the time frame we're putting on goals? Now, this is going to depend on how often your therapist is tracking progress. So like at our office, it's typically between 4 to 6 months that we are writing a progress report and tracking where the child's at toward goals. And then at the schools, it's typically 1 year maybe that they're doing progress. It could be sooner. Some places it might be every month they have to do progress for insurance, but it's important to know what the timeline is because the way we write the goals will be different. You can think more like short-term goals versus long-term goals. So as therapists, when we're writing goals, we're thinking, will the child be able to accomplish this in 3 months or will they be able to do it in 1 year? So it's important to know what the time frame is on your child's goals. And last thing here, I just put some examples. So we can see here, I gave an example of a SMART goal and then a goal that does not meet all of those areas. So if we look at the first one, Sam will produce R in the medial and final word positions at the 5 to 6 word sentence level with 85% accuracy given minimal verbal, visual, and tactile cues measured during a 3-month period. So you can see that's a lot. There's a lot of words there, a lot of information. the goal under, Sam will produce R at the phrase level given assistance. So basically these goals are targeting the same thing, but one of the goals is much more detailed and really lets us know exactly what the child will be working on. So we can see the first goal is specific. We know that Sam is going to be trying to produce the R sound in the middle and final positions of words at the 5 to 6 word sentence level. It's very specific. We know exactly what the expectation for Sam is. Measurable, so you can see 85% accuracy. So if we're tracking data, we're going to track how many times he got the R with some help, how many times he did it on his own, how many times he didn't quite get it. So we have a percentage in there, so we're able to take our data and translate it into a percentage and make sure that we're tracking their progress. Achievable, so that's going to depend on Sam's age. So let's say he's 5, maybe almost 6 years old. So for him, is that achievable? Yeah, you know, he can make the R sound, he's at the right age range, so I would say it's an appropriate goal. Realistic, so if Sam was 2 years old, absolutely not, would not be a realistic goal. But Sam, almost 6 years old, it is a realistic goal for him to be able to achieve this. You know, it also depends on too, if Sam, is he able to make the R sound right now? If he's not, he probably wouldn't be putting it in sentences, but is he able to make the sound? Yeah, then maybe he is putting it in sentences. So again, that goes back to really just looking at where your child is specifically at. And then timely. So I added on here measured during a 3-month period. That will not always be on the goals, but I think if there's not a time frame put on the goal, it's important for you to talk to your child's therapist and ask them how often they will be completing a progress report or reporting progress to you. So even if it's not on the goal, you know, okay, my therapist said every 4 months I will receive a progress report or I will receive some note about where they're at toward their goals. So you want to know what the time frame is. And then for language, I wrote pretty much the same idea. I have a really detailed goal about verb tenses and then a less detailed goal. So just to give you an example of kind of what we would want our goals to look like and sometimes how they're written. So if you see a goal like Sam will produce R at the phrase level given assistance, well, you might want to talk to your therapist and clarify how long is the phrase? Is it 2 words, 3 words, 4 words? Because that can make a big difference. And then given assistance, well, what kind of assistance are you giving the child? So like in my first goal, we had verbal, visual, and tactile, which a verbal cue would be me reminding, maybe I'm reminding Sam, oh, Sam, don't forget to put your tongue back for that R sound. A visual cue would be me showing him, you know, I might have a picture of somebody making the R, or I will show him with my own mouth. And then a tactile cue would be like a touch cue. So maybe we're tracing down our arm to make an S, or maybe, you know, I'm touching the back of his throat to remind him to get his tongue back. But it's really important to have those specific types of cues because then that helps you know how your therapist is targeting the goals. All right, well, that is the end of my presentation. So I'll leave my info up here. So anyone watching the playback has my information for questions. I am going to stop sharing. And I'm not sure if anyone's on Facebook, but I just have Caitlin here. So Caitlin, any questions?
No questions from me, Sydney. Great job. Thank you so much for sharing all of that information with us.
Yes, and thank you to everyone who's watching on playback. If you have questions, feel free to email or leave comments on our Facebook Live, but we are happy to help, and I hope this helps you understand your child's evaluation.
All right.
All right. All right. Well, I am going to end our live.